Welcome to the UK Semiochemistry Network. This is our virtual meeting on COVID-19 and olfaction. We are very lucky to have Valentina Parma, who chairs the Global Consortium for Chemosensory Research, the GCCR, and has done so since March 2020, when it was set up. And this is going to be a follow-up meeting to our earlier, in fact, our first virtual meeting on COVID-19 and olfaction, which was given by Carl Philpott. Parma is an experimental psychologist working at Temple University in Philadelphia in the USA. She is interested in odors and their effect on behavior during development. But with the GCCR, she has been studying the effects of COVID-19 on the senses of smell, taste, and chemokinesis. They have some fascinating findings which have illustrated COVID-19, but are also providing some illustrations about olfaction and its related senses. I'm sure you'll find this a really interesting talk, so Valentina, please enlighten us. Thank you.
Glenys mentioned, I am the chair of the Global Consortium for Chemosensory Research, and we got together many scientists, and this is the current map, but we are approximately 600 across 59 countries as of September 13th. And we gathered together scientists and clinicians and patient advocates and journalists and artists. Like, we all got together because we share an interest for the chemical senses, and we felt obliged to try to find a response after the first reports of patients that got COVID-19 and reported smell or taste loss. And so, as I was mentioning informally before, we started having some threads on Twitter. We're trying to respond to these patients. Some colleagues put together names and Twitter handles and try to grow a big group. And finally, on March 21st, we had over the weekend a call among the people in the leadership team, and I will present them to you a little bit later on. And we tried to find a strategy on how to study with the knowledge and the tools that were available in March, smell and taste loss in COVID-19. And we decided that since this was a pandemic that was touching the whole world, we decided to actually take a global stance to the problem, and so try to gather as many interested people as possible. And we're very proud at this point to be represented across these many regions in the world. And we find that this is not only going to be useful for COVID-19, but it's going to help us bring forward chemosensory science when this COVID challenge is going to be a little bit put on the side, which we all hope it's going to happen pretty soon. So how do we operate as GCCR, and what have we done so far? So this is part of our website, and we welcome anybody who's interested in to participate in the GCCR studies. Of course, we have inclusion and exclusion criteria to the studies that we're going to review later on. But as you can see, we have currently tools in 32 languages, and a few others are coming up. And we're trying to have materials directly in the language of participants to actually spread the information as widely as possible and collect the biggest amount of data possible. We have at the moment 2 ongoing studies, and one that it's gonna come up very soon. And they're based on self-reported measures or on psychophysical measurement of chemosensory stimuli that one can find in their own house. So the survey is our main tool, and is the tool that we have reported on 2 separate publications, and I'm going to delve into the details later. And then we have launched a few months ago the smell and taste check, where people can answer a few questions to contextualize their symptomatology and COVID-19 and their history with smell and taste disorders, if any. And then they're asked to gather in their house some common smell and flavors. And for instance, like a shampoo that we use normally, or a slice of lemon, some salt, and we asked them to actually try and report on their sensory experience based on actually using directly smell or flavors, which is not what we do during the survey. The survey is mostly focused on asking self-reported questions. But of course, as you may remember, in the very beginning, this was pretty much what we could do aside to reach a wide number of people. I now want to go into the details of what the GCCR survey does and asks, because it was meant to actually try to distinguish COVID-19 from other respiratory disorders. And we wanted to do that after the first reports, self-reports that we saw in the literature. We really wanted to expand the evaluation to the sense of smell, the sense of taste, the other sensitivities in the mouth, like the burning or the tingling, so the general kinesthesis idea, and then we wanted to look at nasal blockage. Of course, we also asked a lot of other symptoms that were known at the time and linked to COVID-19, as well as we asked participants to report about symptoms that related to smell and taste disorders in general. And we decided to take a slightly different approach than the one that we saw in the beginning. So we didn't ask binary responses of whether did you lose your sense of smell, but we actually wanted to quantify the loss, and we wanted to evaluate what happened before the disease. And so what people usually reported as their chemosensory sensitivity or generally ability, what happened during the disease, and what happened after the major respiratory symptoms actually faded away. And of course, we captured people at different time points in their disease, and we can actually pinpoint the timing of the symptoms, although this was not the original scope of the survey. As I mentioned, we tried to gather together different questions that quantify smell and taste loss and kinesthesis loss, if any, or just changes in the perception of these chemosensory abilities. And we also include some binary responses because we wanted also to address the question of what is the fastest way to identify the relevant information when it comes to chemosensory symptoms in COVID-19. And our final goal and down the road was actually to be able to predict whether, based on chemosensory skills only at these different time points during the disease, we would be able to discriminate between COVID-19 positive and COVID-19 negative people. So, importantly, as a modus operandi of GCCR, we decided to answer these questions and so explore the differences between the modalities, whether there were qualitative or quantitative changes in smell and taste, try to answer whether the disorders that are related to COVID-19 were more sensory neural or conductive. Again, now we know the answer to this question, but at the end of March, that was pretty much an open question. And we wanted to see whether having different assessment methods could be more useful, and whether, what are the critical differences to discriminate the different types of respiratory illness that are not COVID-19. And this is still very much a point of interest when we know that the flu season is coming up once again. And when we speak to ER departments or other type of healthcare providers, like in the first line of response, then we see that they're very much interested in using any tool they can to discriminate people with COVID-19 from other respiratory illnesses. As I mentioned about the modus operandi of GCCR, you can find at the bottom right corner, like the symbol of, or the logo of the Open Science Framework. And so all of the hypotheses that we have for each of our studies are going to be pre-registered. And so we decide, and we set on the theory, we get together, we exactly decide what is our analysis plan. And after that, once we have the data, the data become available after we have made up our minds on what we want to explore in that chunk of data. And should new questions come up, because as we all have known in this past 6 months, this pace of science is extremely fast, we adapt to perform exploratory analysis on the most novel part of the information that were not conceived before pre-registration. So, but we are blind to what the data are telling us, and so we formulate hypotheses prior to seeing any of the responses that we have from our participants. So the first paper that we friendly call GCCR 001 is focused on COVID-19. So in mid-April, we decided to focus our attention only on people that reported to having had COVID-19, and we came up with a study to investigate, like to actually scratch the surface of what COVID-19 and chemosensation could look like. The paper has been accepted in Chemical Senses, and it is entitled More Than Smell, because at that time, people were highly focused on talking about smell loss, yet we didn't know whether taste or chemostasis would equally be impaired or differentially. So we set out to answer that question. And so we had approximately 19,000 responses at the time, and we ended up considering a final sample of COVID-19 patients that was a little above 4,000. It's impressive that we collected approximately 20,000 responses in 11 days. That was the first time that we looked at the data and that we had. And at that point in time, we only had 10 languages. And all of this is deployed through CompuSense Cloud, thanks to John Hayes and his team at the Pennsylvania State University. So as you can see, the COVID sample came to us in two different forms. So one was a group that was clinically diagnosed as having COVID-19, but there was no lab test at the moment that was available. And it's about a little bit more than half of our sample. And then another part of the group came as a group of COVID-19 patients that had a test, a lab test that confirmed their belonging to the group, and they actually confirmed that they had COVID-19. And as you can see, the average age is approximately 40 years of age. And we span from 18, which was the lowest possible age available for the survey, till 90 plus years old. What about the data? Well, the first data that we looked at was actually the smell rating. And so you can see on the y-axis, there is a 0 to 100 continuous rating that was measured on a visual analog scale. And we asked participants how they perceived their sense of smell to be before COVID-19 and during COVID-19. Lighter shades of color are for the group that was clinically diagnosed as COVID, and the darker shades are for the group that was lab tested. And as you can see, there's not much difference between these two groups in this early point in time, and you can totally see that there is a drop, almost a complete drop, a 0 to all to none type of effect in the smellability. So people who elected to participate into the GCCR survey showed that they had a significant loss of smell due to COVID-19. Was this due to nasal blockage? Well, what we found out with that study was that it supported the idea that this type of disorder is more sensory neural in nature, because many patients reported that nasal blockage was not really there, so their nose was open, yet they couldn't smell a thing. And as you can see here, we have, like, again, no differences between clinical assessment and lab tests, and there is a slight increase in nasal blockage, but it's definitely not an important feature of the disease at this point. When we move to the taste loss specifically, we see that again we have a significant taste loss. The drop is not of the same size as olfaction, yet there is a significant decrease, as you can see also from the distribution of points. And of course, this could be that this is just flavor, and people, when have to self-report, they will just confound what is smell and what is taste, and they would report both. But what we see is that we were, supported in the idea of thinking that there was some type of taste disorder, because 48% of participants reported an impairment of 2 or more taste qualities, and not only just a generalized smell loss, taste loss that was generally reported. So they could pinpoint that they were not able to perceive, for instance, like salt or sweet as well as before. When it comes to chemostasis, this was a very interesting result because we had from patients report that kind of felt all over the landscape in a way. And so people that reported like a chemostasis loss that was significant, we may have all seen the video of the neurologist that was eating the very hot chili pepper during COVID, and really nothing happened. And afterwards, when some of the fun came back, definitely was a lot of crying involved in that experience. What we heard from patients was also, yes, some had an altered chemostasis, some had only nasal chemostasis that was impaired. It is important to note that in this specific case, chemostasis refers to oral chemostasis. And as you can see from the data, we have participants that kind of spun all over the spectrum. So we still have a decrement related to COVID-19 in chemostasis, but it's not as prominent as taste or smell has been before. So when we take all of this data together, well, we learn two things. First is that the smell, taste, and chemostasis kind of all gather together as our left figure that you can see on the slide shows, and they tend to anti-correlate with nasal obstruction. So again, there is this idea that there is a smell loss that is not related to nasal blockage. On the right side, what you can see is that when we try to parse out whether participants could actually be grouped based on their experienced chemosensory symptoms, what we can find is that we can have people that have a smell and taste loss in a significantly or just reduced, and people that have chemostasis loss either in a significant way or not. And although, these groups are not perfectly separated, what we see is that we can identify people that have primarily one of the three chemosensory modalities impaired. And this is also what we have linked to the stories of patients, thanks to the patient advocates that are part of GCCR, and we're talking about Absent, we're talking about Fifth Sense, and all of the other groups that are participating and constitute our patient advocacy committee. After this first report, we actually wanted to really get at the question that we were interested in the beginning and for which the survey was originally developed. And it tried to get at the question of how is COVID-19 different from the other respiratory diseases that may present. And so, as you can see, again, we have a paper that came out in late July, and it's currently meta-archived and it's under review. And as you can see, we have this amazing group of scientists and clinicians and patient advocates that are part of the author list. And the title basically sells the main point. And so the best COVID-19 predictor, at least in our group, is the recent smell loss. And we conclude this based on the cross-sectional study that we run based on the data from our survey. What you can see here is an updated version of what happened up to July 3rd. So we looked at the data cumulatively from the beginning of GCCR till now, knowing that the timeline trends could be a little bit different. And so trying to capture this, what we did was to look at the raw data, which were more than 50K at that unique responses at that point. We excluded a big chunk of them because the majority of people didn't have any respiratory illness, and this was an inclusion criteria for our study. So we're not referring to people that are asymptomatic in any way at this point. We removed people that were unreliable for different reasons, and so we finalized our sample to more than 15,000 people. This final sample is divided in several ways. And first of all, we looked at people with COVID, which are highly represented in our sample. So as you can see, again, we have the distinction between people that were diagnosed clinically with COVID or received the positive lab test. And as you can see here, we kind of over time, like the tests available to people were way more widespread, and therefore we started having higher number in the positive lab test group. After that, as I mentioned, the data that I presented just before on GCCR 001 are related to this first chunk of the sample, and we directly replicated the observations that we did in GCCR 001 in this new later sample that we collected. So after that, we wanted to look at people that had a respiratory illness, but that was not COVID-19, and we only included people that were tested and they had a negative test. And as you can see, the number of people that participate in this group is way reduced as compared to the COVID group. Yet, we tried to make it as clean as possible based on the survey data that we had available. A big chunk of our study includes the people that are unknown COVID, and so people that they may have COVID based on symptoms that they self-diagnosed, or are interested and they notice changes, but they do not know whether they have any other relevant symptoms. And when we look at the smell rating, as the graph shows at the bottom right corner of the slide, you can see that just by looking at this one variable among the many that we considered in the survey, the COVID-19 plus group that was lab tested, that is in blue, the one that was clinically diagnosed, that is in green, and the unknown look very similar to each other. So our hypothesis is that these people actually did have COVID, or the majority of these people had COVID, yet they did not have an healthcare professional confirm this. Whereas the COVID-19 minus people, although this group could have included some people that receive a false negative COVID test, they actually look quite different as compared to the bigger part of our sample. A big caveat for considering our data is that the GCCR survey is an opt-in type of survey, and so only people who decided to participate may have had a special interest either in COVID or in olfaction and taste. And so we do not believe that this sample necessarily is representative of the whole population, although we know that we try to spread the information as widely as we can, and the return we proposed information, advertisement for the survey on Twitter, on Facebook, on many other different social media. We had newspapers and the regular media to showcase our work, and then we had personal contacts as well. So we had, across 59 countries, we really had access to a larger pool of people. Yet we still do believe that people opt in when there is a specific reason. And this, as you may have heard, can be related to collider bias issues. And so what can we really say based on our data from GCCR? And so let's consider for a second a few hypothetical scenarios to look at, some options that we have to better contextualize the results that we get. So if we consider on the x-axis having the probability of having COVID from 0 to 1, and on the y-axis the probability of having smell loss, again from 0 to 1, we can think about two scenarios, for instance. We can consider a scenario like the upper panel, in which there is no correlation between having COVID and smell loss, and so data are going to just be randomly presented and there's no association between them. Or we can even imagine that there is a positive correlation between having COVID and having smell loss. And so we can imagine something related to the lower panel represented here with an R of 0.046. So let's now keep thinking about this. And if we know what happens in GCCR, as we have seen from the makeup of our research subject pool, what we have is that we have a lot of people with COVID and a lot of people with smell loss. And so imagining that GCCR doesn't capture accurately people that have low probability of having COVID and people that have a low probability of having smell loss, let's imagine to eliminate all the red dots that are marked there. Let's just imagine that the GCCR just doesn't capture that part of the population. So what we see is that what is the type of relationship then that we find between COVID and smell loss? And this relationship would be negative. So if we imagine that either there is no correlation or there is a positive correlation, and we exclude the part of the observations that we are not able to capture with GCCR, what we would expect is that we have a negative relationship between COVID prevalence and COVID probability of smell loss. Therefore, if we find a positive correlation between COVID-19 and smell loss in our GCCR sample, these actually represent a quite conservative scenario to find that result. And this becomes even more intuitive if we think that if all of our sample, whether they had COVID-19 or not, they present some sort of smell loss. If we're able to discriminate and to predict who actually has COVID and from who doesn't, then we're really tapping into something that is quite specific to COVID, because the data are actually running against us in this case. When we look to, knowing that our data are representative of the general population, we relied on YouGov data, which is international survey service that worked with the Imperial College London to provide data on, and publicly available data on COVID-19 and general symptoms. Smell loss was not a question that was included at the beginning of their survey, but they very quickly added it. And when looking at that type of data from all over the world, and we don't exactly match all of the country between GCCR and YouGov, but what we see is that they report that at least 33% of people have some sort of smell and taste loss and also have COVID. So of course, as we know, our data in GCCR are over-representing smell loss in this sample. So that's why we do not talk about prevalence at any rate, but we just try to describe what happens in this more extreme type of sample. So one of the first questions that we had with GCCR was, can we actually predict a COVID-19 from COVID plus from COVID-19 minus? So those who are negative and those who are positive, are we able to distinguish them based on chemosensory skills? And to answer this question, we only focused on people that had a lab test that came out either positive or negative. And the results that you can see here, let me move this window around for a second, we confirmed that there is also in this, both in the replication and also in the cumulative data, which is what I show here, there is a significant smell loss as compared to COVID-19. And you see that the distribution, it's actually similar to what we have seen in GCCR 001. We then have a significant taste loss that gets confirmed. And again, we have a slight reduction as compared to the smell loss reduction during the disease that we have explored before. And we have a significant reduction in chemostasis, although as you can see from the graph itself, is not as striking as for taste and smell. So conceptually, we do replicate our concepts from GCCR 001. I see that there is a message, and sorry, I have a hard time checking where it is. So give me just 1 second. But it seems to be okay. Ooh, I don't know why I don't see my cursor. Give me just 1 second that I close this window. Okay. So nasal blockage, again, doesn't seem to be different in COVID-19 and COVID-19 minus, but again, we have a group of people that tend to have smell disorders. And so when we look into the literature, it actually seems to confirm the idea that nasal obstruction is not part or is not a core sign of COVID-19 as we hypothesized in the first study. So then we keep moving with this idea of the prediction and how do we do that? Of course, the questions are many, and we started to linearly think about what is the easiest way to predict the distinction between COVID-19 plus and minus. And so we start with binary questions. And as you can see, when we try to predict whether you have COVID-19 plus or minus, and we just use yes or no questions, the top questions that do the best job at that are questions related to smell. Do you have any changes in smell during the disease? Any anosmia or hyposmia? Any changes in food flavor? Those are the top. Interestingly, when we look at fever, which is one of the signs that it's currently used to detect a disease, you know, at least here in Philadelphia, if you try to go out to a restaurant, they will take your temperature first, and I'm sure this is a practice that it's quite widespread. But fever doesn't seem to be at all good, at least in our sample, to discriminate between COVID-19 plus and minus in a reliable way. We started then to kind of complicate the measurement a little bit. And so we expressively decide to include the quantitative questions that went beyond just the binary yes and no. And so here we looked at all the possible questions we had in the survey and what are the best at discriminating COVID-19 plus and COVID-19 minus when taken alone. So if I just have to pick one question, which one it is that gives me the best chances to find out who are the people with COVID-19 and that show some respiratory symptoms. So in the first 10 features, you can see that they're all chemosensory in nature. Here we have sore throat, fever, aches, muscle aches, like all of the other symptoms that we now know, or dyspnea. Those do not seem to be, at least in our group, be predictive of COVID-19. Yet, asking questions about chemosensations in different ways really matter to get the better result or the best result. In our case, asking a question that is a 0 to 100 rating on a visual analog scale, and specifically it is how is your smell during the illness, allows you to actually discriminate between COVID-19 plus and minus with an ROC AUC curve of 0.7. When we just ask a binary question, we almost lose 10% in this analysis. So as we can see, like even if we want to evaluate smell loss, asking a question that is more graded will help us find out more cases than just if we ask a yes or no question. When we try to actually even complicate the story, so we allowed us to create models that are not just including one feature, but they're actually composite and they can look at multiple features altogether. We start by looking at what the CDC in the US was doing. So we started looking at fever, cough, and dyspnea and their report. And we see that in our group that has a 0.54 ROC curve detection rate, which is not much better than chance. Like it's not very different from the flat line that we see in the middle. So if we just consider smell alone, so smell during illness, we can see that we can increase by 15% at least what the CDC triad can do when it comes to discrimination between COVID-19 plus and minus. The best model and the best parsimonious model in our survey just includes the smell during illness and days since onset of the disease. So that gives us 0.72 as the ROC AUC. So this tells us that smell definitely, it's one of the best ways to identify COVID-19 and discriminate. And this is not only on GCCR, and although it is impressive what we have done, because again, smell loss was one of the features across our COVID-19 plus and COVID-19 minus groups. But you can see, I reported here many papers that were either published or are currently archived that actually concur with this idea that smell is one of the best predictors of COVID-19. And the fact that this is independently revealed in different samples that are based on self-reports on outpatient clinics in different countries actually strengthen the idea that we're onto something with this type of data. We also timidly wanted to look at with GCCR 002 to smell recovery, because knowing that the first people started being diagnosed in March, more or less, and we were looking at the data in July, we thought the 4 months was a good initial time point to have an idea of how people recover and what are the features of that chemosensory recovery. So we are very well aware that this is just the initial part of the recovery. And what we can say based on this first chunk of data is that we can identify 3 different types of groups based on the smell change, which is the change in their ability to smell during minus before the disease, and their smell recovery, which is the change between the ability of smell after the disease versus during the disease. And as you can see, the upper panel reflects like a COVID-19 plus people. You can see that we have approximately 3 different groups. So one that is 8.5% that has intact sense of smell. So they do not, they're a minority, but they don't have any type of chemosensory symptoms related to COVID. And then we have 2 groups that are either they present a persistent smell loss, and they're approximately 50% of our sample, and there is another 40% that had significant smell loss, yet they recovered. And if you look at the upper right panel, you will see that we tried to understand what was the time course of this recovery. And what we can see is that the smell change, irrespective of when you had a diagnosis of COVID, like it's pretty much stable across the days since onset with the progression of the disease. Yes, the smell recovery tends to increase over time and kinds of plateaus around 25-30 days. When we compare the data of these 3 groups, that 3 chemosensory recovery profile, what we compare them to the C19 group, we see that we have a similar distribution, yet the percentages are very different for the 3 different groups. So first of all, there are approximately 30% of people that do not lose their sense of smell. Those who have persistent smell loss are 39% or 40%. And then we have another third that actually recovered their sense of smell. And just by the color of the heat map, you can see that the probability of having a smell loss in COVID-19 minus is less likely than having smell loss in COVID-19 plus people. So these are only initial insights on recovery. And so by looking at the literature, we can say that there is an average of 3 weeks recovery. And I'm sure you all have a more direct experience even with this. And that the majority of people tend to recover by 60 days, whereas at least 15% seems to show impairment after 90 days and perhaps longer. So what seems to be happening is that taste is reported to recover faster than smell, yet we are seeing more and more, at least from the reports that the patient advocates are sharing in GCCR, that parosmia is becoming one of the main symptoms. Interestingly, this is not what we saw with GCCR 001. So as of April 18th, the rate of parosmia was very low at that point in time. But it's definitely increasing right now, and it's becoming a problem that needs to be addressed, and that we hope to actually look into with our follow-up survey. Importantly, what we try to do with our GCCR data and with the ability to predict based on this visual analog scale measure of smell during disease is we try to create a quick tool that can be used clinically to discriminate between COVID-19 plus and minus. And so our rationale was, if we look at panel A, what we see is that we plotted the probability of having COVID-19 based on the smell during rating that one provides. And as you can see is that if that rating is below 20, you have a high probability of 0.8 to 0.1 of having COVID-19. And therefore we tried to mimic the pain scale and transpose it into chemosensory terms. And we presented this Odor 19 scale where we have a rating from 0 to 10 with the odds ratio of having COVID. And so if it's 0, the odds ratio is pretty high. 2 represent our cutoff, and 3 should be actually a borderline measure that people should start focusing on. Importantly, of course, any of the tools that uses smell loss to guess whether somebody has COVID or not needs to be mindful of the fact that people with smell and taste loss exist, and they could be completely unrelated to COVID-19. And so our attempt in this Odor 19 scale, it's just to exclude everybody who has a known smell and taste disorder, and then try to actually screen people very grossly with the Odor 19 scale. And should you find any worrisome information where the risk is moderate to high of having COVID, then move forward to further testing. We are currently trying to validate this scale in clinical samples and against lab tested work, but we do not have this data available yet. And so I will be happy to share them as soon as we have them. So what is next? So as I was mentioning before, we're trying to look at a follow-up study from the survey. So we are recontacting back the people that already responded to the GCCR, and we want to see what is happening with them a few months after they actually first responded to GCCR. We are about to look at the data from the self-check, and so trying to link these subjective questions with more psychophysical studies that are run with a non-standardized stimuli. And on top of that, we have a lot of groups that are creating like a sub-research questions based on the GCCR data set that is available to all of the members. And they are proposing different types of study. In one that is in its final, it's being processed, and hopefully it's going to be formally accepted very soon with the French group, and the leader of the group is Denis Pierron, and it's work done with Mustafa Ben Sapri, Jérôme Golembiaski, Valeria Perederloth, and Camille Ferranzi, among many others. What we're showing is that using self-ratings of smell and taste loss, even if it's a binary question, we can actually predate the overwhelming of the healthcare system in France by 10 days, which is a much better result as compared to what the governmental index that was currently used is doing. And so the governmental index would be able to predict just 3 days earlier the overwhelming of the healthcare system, whereas if we monitor in a certain area that smell and taste loss is reducing and people are actually reporting significant smell and taste loss, we can actually predate by 10 days the overwhelming of the healthcare system. And all of this points in the direction that actually olfaction has relevant clinical information that is definitely useful for COVID-19, and we should be able to focus on it and to lean it a little bit more, and definitely use it as a tool when it comes to for the upcoming flu season. And on the other hand, I realized by talking to journalists and to other stakeholders that the general public really doesn't have a good idea of what olfaction could be used in terms of clinical terms that are not directly related to smell and taste. So linking the sense of smell to the idea of an infection and to the idea of diagnosis of that infection is not that intuitive. And so I think it's on us to actually keep talking about this and try to make this point and help people understand that olfaction can have a very important clinical relevant consequences for public health. If you are curious about GCCR and you want to know more, please go to our website. I know the name is a little bit difficult, but you can, I can share my slides later on. You can follow us on Twitter. You can look at our Facebook page. And so we're happy to welcome any other interested members for collaboration. Of course, I have to acknowledge the work of the leadership team, and this group has been amazing, and we really met pretty much every day since the pandemic. And right now, like, we're slowly, after GCCR 002 was submitted, we have been seeing each other a little bit less. But in order, like, Chrissy Kelly is the patient advocate that started GCCR with us, and now Nina Hill from Fifth Sense took her place in the GCCR. There's Danny Reed from Manel, Katrin Ola, Masha Neve, myself, Thomas Hummel, Steve Munger, Marga Vildoizen, and John Hayes. So this is, I'm very honored to be part of this dream team and to push forward the chemosensory research on COVID-19 and to try to push forward chemosensory research beyond that. But of course, we're not alone. This is just like a brief, like a summary of some of the people that are part of GCCR, because we cannot really fit 592 people at the moment, but maybe we'll get to the point where we'll do that. Hit me up on Twitter, look at my website, write me an email if you want to know more or you want more private information. And I'm happy to answer all of your questions now. And thank you for your attention.
Valentina, thank you very much. That was an absolutely fascinating talk. And I love your slides. I mean, do you have a graphic designer in the team?
It's just me.
Wow, well, they're very impressive. Very impressive.
I appreciate that. Thank you.
Can I take the chairman's privilege and ask you the first question, please?
Please.
A lot of my patients are on intranasal corticosteroids, which probably reduce ACE2 receptors in the nose and probably particularly on the sustentacular cells, which are perhaps affected by COVID-19. Do you ask patients about their therapies as well as asking them about their sense of smell? Because steroids could be protective.
We do, and so we have some teams that are working on text mining at the moment, because those questions are open questions. And so let's say that the first approaches that we took was actually to analyze the data that were easily available to us. And we have a lot of questions that are open questions answered in all the different languages the 32 languages that we have. And so we have text mining teams that right now are finding the best ways to analyze and extract that data, but I don't have any information about medications at the moment. Okay. That information, it's not going to be fully precise here, because we really needed to balance like the breadth of the information we were investigating. And this survey is very long. And so people, some are very motivated and want to answer, and some others are just answering in a way that we really need to be quite creative to understand what they meant and time-wise, what exactly was happening in their lives. So we're working on it, but I expect the number of responses and the precision of responses not to be great, but it's definitely a point we will want to explore.
Okay. If you'd like to ask a question, please feel free to do so. Either if you've got your picture up, raise your hand, or there is a function at the bottom where you can press the little buttons underneath more.
Question from Sani. So he says, do I understand correctly that the estimated overall prevalence of smell and taste loss is 33%?
So that is, the prevalence has been reported like very wildly, I would say, in the literature, and mostly it's related to a non-randomized sample. So we relied on YouGov, which is a randomized sample of 1,000 people over, right now, I believe 24 weeks for the countries that started in the beginning. And I actually looked at the data yesterday, and overall, we have across all countries a 33% rate. However, this varies extremely by country. And this is linked to two questions. One is, do you report loss of smell, yes or no? And I didn't include in this count, did you report loss of taste, though the majority of people are overlapping, although not precisely. And where you tested for COVID-19, and did you receive your results? And the results has to be positive. And they're looking at, I think, if I remember correctly, it's more than 300,000 participants, but those that have COVID-19 with confirmed are approximately 5,000. So, but this is our best guess at a randomized evaluation. Then in the literature, I've seen, we have 90% in GCCR, but again, people elected to tell us that they had smell loss and they had COVID, so I wouldn't take that as a prevalence. But we saw in the literature 50% to 86%. It also worth noting that we may think that this is an all and over representation because people are self-reporting, but actually when we look at the data from Mackenzie Hannum and Danny Reed from Monell and their meta-analysis, what we see is that if people are evaluated through objective measures, we actually increase more or less by 20% the ability of seeing smell and taste loss. So we can consider that 33% as a self-reported, evaluation of the people who are in a randomized sample. But if we tested those people, I believe we could have approximately 20% more. So I think it's safe to say that, we could guess that it's a 50-50 chance at the moment with the pockets of group that have an overrepresentation of smell loss. How are these related? Like, we're also trying to look at the different types of symptoms between COVID-19 and smell loss. Honestly, we didn't see in our prediction models anything that really created like some cohesive like groups at that with, fever or dyspnea or other type of symptoms. So that's my best guess at the moment.
The problem that the test is only 70% accurate is also difficult for you.
Well, that's, we're assuming here that the tests are working very well, but yeah, there could be that 30% is still not good. We're actually looking at some data on separate from GCCR, but I'm working on a project. I'm trying to develop a smell test, and there are some people that we've talked to that really believe there could be this type of less sensitive test and more easy and faster to produce results. It could be perhaps more beneficial than actually having a test that is highly accurate with a 70% rate of accuracy, letting alone the fact that if we look at the cycles of, the level, the viral level where we put the cutoff is different for different healthcare providers. There was a very nice article on the New York Times, if you have the chance to read it yesterday, but they do not even agree, and there's not CDC guidelines in the US on where the tests should stop in terms of cutoffs. So it could be that we're diagnosing people that have some virus, but it's not active viral load and could not be contagious. But yeah, we're thinking in terms of broad estimates, I think, at this point, and maybe the precision will come a few years down the road. That's my hope, but there's still a lot to know.
Okay. Tristan Wyatt has kindly pointed out how to ask questions. You click the participants button, and then you get the option of a raised hand. We do have a question now from Carl Philpott.
Thanks. Yeah, lovely talk. I was just wondering what your thoughts were on what the data says about the theory on the sort of pathophysiology of how coronavirus is wreaking its havoc on the chemosensory system.
Yeah, so I think, I'm a psychologist, not a biologist. That's the first disclaimer that I'm gonna say. But I have been talking to people. So what I really feel comfortable saying based on this data is that it seems that we have some sort of sensory neural disorder, and based on the data from Bob Data's lab, that seems to be not directly linked to the neurons functioning, but the sustentacular cells. Having said that, I'm not sure what we can say more with this present data. We're trying to partner with, we were contacted to partner with some groups that are doing genetics. And so my hope is that people are going to answer GCCR questions that are very deep in terms of chemosensory evaluation. And then we will have some genetic markers related to that we can explore. Still going to take some time. For the mechanism, I think this data can only speak to the phenomenology, and I don't think we can. The rest would be all speculation. There's a review that we wrote with Bob Data and others, like Cooper is the first author that we can refer to as general hypothesis on how what could be the mechanisms that could be at place. Some of that is of course dependent on GCCR, but I think we need to use the data for what they're useful for, and speculation. It's part of the game, but I'll take a step back on that one.
Okay, does anybody else want to ask a question? No. Right. Well, I think in that case, Valentina, it remains me to thank you very much indeed. Oh, sorry, we do have a question. Oh no, we have clapping hands from John Hayes. Thank you. It's been a fabulously interesting talk. I think we've learned an enormous amount, and I think you've expressed it extremely clearly and graphically. Thank you. And we look forward to looking at your website and learning more in the future. Good luck with your future investigations. And
thank you so much. It was really a pleasure to be part of this group. I'm very, very honored. So I hope there will be chances to meet in person when you know, normal life resumes.
That will be lovely. Yeah, roll on normal life.
Exactly.
Thank you. And thank you all for attending. It's a pleasure to see you all, and we'll keep you in touch with our next meeting. You'll be hearing from Simon before too long.